Good morning and welcome to the live stream spine surgery performed at Duke Spine Institute on April 11th at Snake Eyes 11 today, April 11th, 2023. I'm Dr. Ara Duke-Majan, CEO and founder of Duke Spine Institute. Our patient presents to us from Washington State. Yes, her son is from California, who's also here. And she has two herniated / degenerated discs in her neck at C5-C6, C6-C7, the two most common discs to cause problems for patients that end up needing to be fixed with surgery. Her problems are neck pain for over 5 years and pain going down into her left arm with weakness and numbness and tingling in the left arm. These are symptoms that are due to nerve root pressure by the herniated disc within the neuroforamen. So she was offered fusion surgeries. She didn't want it. Artificial discs were not a good option either because both fusions and artificial discs are going to affect the movement of the spine negatively, cause adjacent segment disease. They require big incisions with lots of scar tissue. She found the Duke laser disc repair, the most advanced, least invasive spine surgery available to fix herniated or degenerated discs that cause neck pain and arm symptoms. And she's here, traveled to Florida for her surgery. We're going to get started. We're going to be doing a C5-C6, C6-C7 Duke laser disc repair. Just to orient you, this is the front of her neck, and I'll show you the middle of her neck.
You want a marking pen?
Yeah, where's the marking pen? Well, let me just show you with this needle, which we'll be using shortly. The center of her neck is here, okay? Just to give you a little bit of the anatomy, her chin is right here. Her eyes are here. Nose right here. And the middle of her neck is literally right here, okay? Her collarbone here, another collarbone here. So it kind of orients you as to where we are. This is her, the bottom of her, the bottom of her chin is here. This is her mouth, and this is the side of the neck here. So because it's her left arm that is the primary symptoms, we're going to start on the opposite side, and it just makes it easier to get across the middle. I'm going to show you the technique that was taught to me by the Koreans 16 or 17 years ago when I started doing these surgeries. And the technique is for accessing the disc. You have to go between the trachea and the carotid sheath, which is just behind the sternocleidomastoid muscle right here. So I'm going to go between the two of them, and you have to use 2 fingers, and you have to touch the spine. And the only way this is possible, by the way, is when the patient's intubated and chemically paralyzed with medication, so there's no muscle contractions. All right, so we're a little bit overexposed. Let's get a better picture. 2, 3, 4, 5, 6, 7. So we're down at 6, 7. I need to go a little bit higher, and I always want to start, if I'm doing 2 discs, 5, 6, 6, 7, I want to start in the middle of the C6 vertebral body. So I can go up a little bit and down a little bit. All right, 2, 3, 4, 5, 6, 7. Still a little bit too low. I need to move up just a little bit. And again, I'm just walking up the front of her spine. Shot. All right, there we go. So that's C6. Show us C6. 2, 3, 4, 5, 6. Let's move that little clip, Dr. Berndes. It's in the way. Okay. That's going to be under the sterile drape. So I'm going to start by going down a little bit. To do that, I'm going to slide my fingers down. Shot. There we go. And I'm going to go down to the spine. Shot. All right, so I'm a little bit above the C6-7 disc. I'm going to reposition and go down. Shot. There we go. All right, now let's see. We need to be in the middle. Give me an AP. So we're going to check our front-back view to make sure we're in the middle. I may have to make an adjustment. Quick shot. I'm using, perfect, we're right in the middle. I'm using radiation gloves for those of you watching. And while radiation gloves do afford some protection against the radiation of the x-ray machine, they are not completely protective. I need to be able to see. I don't see my needle. Take another shot. Come on, Jordan. We don't have a lot of time here. There we go. Alrighty. And I believe we're in the middle there. So let's get one more picture just to make 100% sure. Go AP. Quick AP. Shot. That looks perfect. So you can see the tip of the needle is right in the center of the spine. All right, shot. I don't know why I'm having trouble seeing that. It's probably my thumb. Shot. Yeah, that helps. All right, we're going into the disc. I could feel us passing through the annulus. We are inside the disc, and I'm now in the center of the disc with the needle. Too overexposed, Jordan. You got to turn down the radiation. She's got a thin neck, small shoulders. Come on, I shouldn't have to tell you these things. It's obvious. Every time you're turning up the contrast, it means you're overexposing. It means you're applying too much. Okay? So now we're going to do what's called a discogram. Shot. Give me a shoulder pull.
Yeah.
Shot. And we want to verify that this patient, we are at the C6-7 disc. Shot. Come on, Jordan. I got a C6-7. There we go. All right. So 2, 3, 4, 5. Count with me, Jordan, so we know what we're doing. 2, 3, 4, 5, 6, 7. Good. So we are at the proper disc. Blood pressure is good?
Yes.
There we go. Shot. All right. Now, someone's hand's in the way, Luis. Shot. All right. You can see the dye going out the back of the disc, and it just gets real diffuse. So, with the cervical spine, we don't do evocative discograms. We do chromodiscograms. There's a difference. The patient's asleep. It's not possible for us to shot. That's nice. Not possible for us to record a response from the patient, okay, because they have a tube in their mouth. So they're not going to be able to give us a response. We've got our guide wire in. We're going to do the entire surgery through a 4mm incision. I'm going to numb up the skin. This way the patient doesn't have a sympathetic response. Knife. I'm going to make an incision. It's going to be 4mm. The whole surgery will be done arthroscopically through this 4mm incision. I use an 11 blade stab incision. You don't want to go too deep, because what's down there, you have your carotid artery, jugular vein, trachea and esophagus, among other things. So you want to be very careful. I'm going to remove the spinal needle, but I'm going to keep an eye on my guide wire. Shot. Make sure it doesn't go in or out. Okay. Needle is out. Now I'm going to run my dilator down the guide wire. It's like a long skinny pencil. This does not do any damage at all. It actually spreads the fibers of the fascia and muscles under the skin. And the way I put it in, shot, you got to watch your guide wire, make sure the guide wire doesn't advance. You can see it's passing the trachea and esophagus. Show us the trachea, endotracheal tube. Okay, endotracheal tube is there. Can you see that, guys?
Yes, we can.
And then the esophageal temperature probe is the braided one in the back, all right? So it's passing those two structures, trachea and esophagus, and we are in the front of the spine. Let's get an AP view. We're going to go to the AP X-ray view. You can all see how tiny the incision is. So one of the things patients like about this surgery is that it's a fast recovery with a Band-Aid incision. Another thing, see how the tip of the dilator is almost in the dead center of the spine? That's really good. You want to be in between the longest coli muscles for the surgeons out there. You want to be right up against the anterior longitudinal ligament, which we are. All right, so now I'm going to advance this dilator through the anterior annulus. Okay, and again, it's not damaging anything, it's just spreading the fibers open. When we're done, I can take it out, and then the fibers are gonna come back together on their own. Shot? So she has a herniation here at C6-7. Just, again, you're just overexposing everything. Yeah, it's pretty degenerated disc, but you could see the tip here. Part of the problem, Jordan, to be quite honest, is that you have too much skull and upper cervical spine. You should be a little lower into the shoulders so that the X-ray machine understands the tissues down here that it's trying to penetrate. Okay, that's better. All right, we have a little inline traction going.
Yep.
You can see the tip of the dilator is now at the back of the disc. And all the blood we've lost for the whole surgery is like 5 drops of blood, which 5 drops of blood is 1/4, 25% of a cc, which is a milliliter. If you have an anterior cervical discectomy infusion or ACDF surgery as an alternative, you're going to lose 100 to 500 cc's or milliliters. So you're going to lose about 1,000 times as much blood as a Duke laser disc repair. Sean? All right, I need a shoulder pull and I need inline traction, not too hard. We want to distract the disc space in order to get the retractor in. So I have my anesthesiologist, Dr. Berndes, is gently retracting inline traction on the head to distract, and my assistant, who's back there, Oscar, is doing some gentle pulling on the arms downwards towards the feet. I think we're just about there. Huh? That looks pretty good, right?
Yeah.
So we're at the back of the disc, right where the herniation is. Now, a lot of people, when they look at this picture, they think, oh, but there's a huge tube in the disc, right? But let's give an AP view so they could understand. Look, see the tiny incision? 4 millimeters. It fits the tube perfectly. We're going to get an AP view, front back view, and you can see how the tube doesn't take up much space. Show us, Jordan, the tube in the disc. There it is. Okay, and there's the end of the tube at the back of the disc. And show us the width of the disc, side to side, from there to there. That's correct. Okay, so you see the tube is actually quite small compared to the size of the disc itself. All right, we're going to take the X-ray machine out, and we're going to start our Duke laser disc repair. But before we do that, I'm going to have my team, Henry and Jose, run a video for you explaining why do herniated disc, bulging disc actually cause pain in your neck. How do they do that? And the answer is inflammation. So go ahead and give me a countdown and let me know when that video, educational video, is playing. we are,
Cervical scope, OR1. Cervical
we're going to change out our scope. So our fiber, our laser fiber, needs to be stripped, meaning we're going to take some of the blue plastic coating off the fiber and expose the tip. So we're getting that taken care of. We're changing out the scope. Are there any questions from our audience
Yes.
while we're doing that?
Yes, we have a question from Jonah on YouTube. And they asked, hey, is this procedure good also for the C7 to T1 level? Another question, when you approach the disc from the front, it may impair the integrity of the disc itself in compression to a posterior approach like foraminotomy?
Yeah, it's a great question. So the question is, the cervical disc herniation, it can be approached through the front or you can approach it through the back, posteriorly. The problem with approaching through the back is the disc is actually in the front of the spinal cord, so you're never going to get the herniation out through the back. The herniation is the problem. The herniation's in the front. The only way to get to it is through the front. If you go through the back and do a foraminotomy, you're opening the roof of the neuroforamen, but you're not taking the herniation out. You're leaving it there. That's why foraminotomies don't work, and I don't recommend them for patients. Now, the other problem with going through the back is you're going to make a big incision, and you're going to damage the muscles in the back of the spine if you do a foraminotomy. There's no way to do a foraminotomy without damaging muscles, creating scar tissue, and excessive bleeding. So foraminotomies are really bad procedures. They're destructive to your body. They damage and destroy the normal body, the normal muscle, the normal ligaments, the normal facet joint gets destroyed. You're actually opening the foramen by removing the facet joint. The joint is necessary. It'd be like removing one of your knees. It's a weight-bearing joint. It's important in restricting movement. And if you start taking the joint out, it creates instability. Patients end up needing a fusion as a second surgery. So with the Duke laser disc repair, we're not destroying anything. The tube is passing through the disc. It's a small tube, a small disc, a small hole. Therefore, there's no damage done to the disc by the procedure. That's one of the things people don't understand often, is they think that passing through the disc is going to destroy it, but it doesn't. The disc is made out of jelly in the center, and you can pass through it without problem. All right, so here we are. This is the very best surgery in the world for a herniated disc in your neck. It's transdiscal. It was taught to me by the South Koreans and Dr. Sebastian Reuten, a German surgeon who's a pioneer in this technology. But the actual application of laser technology and an annular debridement with the laser is my creation here at Duke Spine, and that's what takes the neck pain away. So my predecessors who taught me the original technique of how to get to the disc, how to use the tube, the endoscope, they didn't use the laser, and they just did a mechanical discectomy with a pituitary rongeur. And they never got rid of people's neck pain. They only got rid of their arm pain and the weakness in the arm, numbness in the arm, okay? So they did it for radiculopathy to decompress the nerve root. However, the Duke laser disc repair took that technique and improved on it to make it better by adding in what's called the annular debridement. And the annular debridement is what you're watching right now with the laser. We're actually using the laser to clean the annular tear. That's going to allow the disc to heal naturally on its own. The other surgeries that were done endoscopically by my predecessors, the disc would never heal. And the reason it wouldn't heal is because they didn't do an annular debridement. You really have to clean the annular tear in order for the annular tear to heal. If you don't do an annular debridement, you're not going to get the annulus healing. Right now we're looking at the back of her disc. This is C6-C7, I believe. And these are all herniation and scar tissue and inflammatory tissue right here. You can see the end plate, which is the bone right there. This is really stuck down to what's called the posterior longitudinal ligament, which runs in the back of the disc. So there are bone spurs here, which we're removing with the laser. we're a little bit overexposed, and there's a lot of herniated fragments. All these little things floating around are pieces of herniation, like that one right there. So we're going to float it out through the tube, and it's gone now. Are you going to have that other scope looked at then? Yeah.
Yeah, definitely. That one. Yeah.
I would take it down. Do we take it down one level? Do we take it down? Here we go. Yep. So this is why this patient is having neck pain. This is why she's having arm symptoms, is these herniations in the back of the disc that we're here to clean out. Notice how I'm moving the tube side to side, and you're going to see it move even more. If you remember the x-ray that we just took a few minutes ago, the tip of the tube is in the middle of the disc. That's kind of where we want to start. And then we're going to move it off to the sides where the neural foramen are, and that's what I'm doing right now. Henry or Jose, whoever's there, would you guys run the video that shows how the Duke laser disc repair actually works? The educational video, please.
Disc herniations are a common cause of chronic neck pain. The inflamed annular tear causes neck pain. Inflammation of the nerve roots causes arm pain. A Band-Aid-sized skin incision is made. A small tube is inserted without damaging the bone or soft tissues. The laser removes the herniation and debrides the annular tear. The annular tear heals on its own. It can take up to 12 months. If you have a herniated or bulging disc and neck pain, submit your MRI for a free review at www.mri.dukespine.com.
See, I'm breaking it up into little pieces. The nerve root's going to be just underneath that thing. That'll be the C7 nerve root because we're at the C6-7 disc, right? There's a piece of herniation right there. It's already jiggling around. So, by the way, there's no other way to remove these without the laser. People say, why do you need the laser? The laser is the very best tool in the world to get rid of these herniations, because these are, remember, that fiber is 0.5 millimeter, okay? 0.5 millimeter. Think about how small that is, but it looks huge, doesn't it? In the endoscopic view, it's magnified. And the reason is that's the whole purpose of the system, is to magnify the view and make it safer to do surgery. This is not the view surgeons get during an ACDF. They don't see this kind of detail. So that's why ACDF results are not so good. And the complication rate is so high, because you can't see really what you're doing back there. And you really need a microscope to do an ACDF, and about 90% of spine surgeons don't use a microscope to do an ACDF. They just do it with loupes, which are not adequate to see enough in the back of the disc to be safe. The complication rates for fusions on the neck are 50%. That means half of the patients having a fusion are going to have a complication, okay? The Duke laser disc repair you're watching, we've never had a complication in 16 years. These are bone spurs, by the way, that I'm removing. You see that? Just got rid of one. Ooh, my hand is cold. All right. So, cleaning out the foramen. I'm going to come back to that in a moment. I'm not done yet. A lot of scar tissue here from chronic inflammation. What is inflammation? Inflammation is your body's defense system attacking. And why would your body be attacking this area? Well, because quite honestly, your inflammatory system's not that smart. Oh, there's a piece of herniation. Do you see it come out? All right, that's what I'm talking about. There it is. So that's just one piece of herniation at this disc. Remember, this patient probably has 30 or 40 pieces of herniation at this one disc by itself. So what I'm doing is, when the herniation's too big, it's too dense, it will not float out of the tube. So you sometimes have to cut it in half with your laser. And if you cut that herniation into little pieces, what happens is they're easier to get out. Okay? That's a bone spur right there. See how the laser just melts the bone spur away? Goodbye, bone spur. People ask me, can the laser get rid of bones? Of course it can. The lasers are used to cut steel, folks. Your bone spurs are not as hard as steel. Steel is harder than a bone spur, trust me. Actually, that's what we use in ACDF surgery, fusion surgery. We use steel, stainless steel drill bits to remove bone spurs. So if a laser cuts steel, who do you think's going to win in a fight between a laser and a steel drill bit? The laser, of course. So all this nonsense I hear about how lasers can't remove bone spurs, of course they can. Lasers are used to make drill bits. They're the thing we use to cut the steel. So lasers are definitely more powerful than any kind of metal surgical instrument. Another bone spur here, okay? We're not trying to get all the bone spurs out. That's not my job. That's not our goal. Our goal is to get rid of her symptoms. There's a bone spur that needs to be removed. So you got to know which bone spurs to remove and which ones not to. And the ones that I know need to be removed are the ones that block my access to getting rid of pieces of herniation that need to come out, or they're actually pressing on nerves or spinal cord. And then I need to get rid of them. Okay? A lot of people misunderstand bone spurs. They think bone spurs have to be removed in order to have a successful surgery, but actually the bone spurs rarely need to be removed. It's not common to have to remove a bone spur because bone spurs rarely cause any symptoms. It's the herniation that causes the symptom, not the bone spur. All right, so I'm removing a little bit of disc osteophyte there, some more bone spur. This is probably the most bone spur I've removed in a patient in their cervical spine in the last 5 years. Honestly, if you go watch all my videos, they're all online. Henry, do you remember any other surgery where we removed this much bone spur?
I can't say at the moment.
Yeah. Yeah, I don't remember any surgery recently where I removed. Luis, how about you? No? Yeah. Yep. All right. Well, the good news is we've gotten a lot of pieces of herniation out, and I'm pretty close to being done with this one. I'm just inspecting this area here at the back of the disc where the herniation is. This is not actually the disc that those bone spurs right there are the back side of the vertebral bodies. So that gives you an idea of where we are, if you understand the anatomy. We're at the back of the disc in the epidural space. And this is scar tissue. The problem is I'm not here to remove scar tissue, I'm here to remove herniations, but sometimes the scar tissue locks in a herniation, and you won't know it's there until you remove some of the scar tissue. And then you'll see the herniation socked in by the scar tissue, locked down. And the only way you're going to get it out is by using a laser to remove it. That's why the laser is so much better than metal tools. Metal tools cannot get rid of scar tissue. Not in these tight spaces. You have to have a laser. The laser is essential. All right. Taking a look at the other side once again.
Fibers. Can I check the fibers?
Yeah.
Thank you.
We have a question.
Sure.
This comes from Jonah once more on YouTube.
Jonah, you got out of the whale. Wasn't that Jonah in the whale? Am I right? Huh?
I guess so.
All right. Got out of the belly of the whale
Yeah.
to ask us a question.
And they
Jonah, welcome to our live stream, and thanks for, oh, look at that herniation right there. Holy mackerel. That's a big one. That was over on that left side. Sorry, go ahead and ask your question.
The question is, how do you keep the esophagus safe when you insert the needle?
How do I keep the esophagus safe when I insert the needle? Well, I use my fingers to deflect it. That's how we do it. It's surgery. In surgery, your surgeon has to keep things safe. That's our job. And the way I do it is I have a lot of experience, and I basically move it over to the side. And I move the carotid sheath over, I move the trachea over. That's how you do it. With your, yeah, and I put a temperature probe in it just so I can have a little bit of extra substance to it. Easier for me to manipulate it when it has a temperature probe. Okay, good question. And then of course, during the surgery, the esophagus is protected by the tube, the tubular retractor. That's the tube that's sitting there in the neck. Why is this pedal not working? I'm stepping on it, it's not working. Is the laser on?
Check.
Yeah, it's working now. Yeah, the orientation of the pedal has to match my foot, which I think it is now.
Yeah, it is.
All right. Great question from our audience, from Jonah.
Carefully.
What's wrong?
Everything good there? Yeah.
Everything okay? Berndes? Huh?
There's a lot of weight on the tube.
Which tube? The endotracheal?
Yeah.
Oh, interesting. You mean right now?
It's fine now.
All right.
Notice it.
Look at these pieces of herniation. So look what I have to do with the laser. I have to cut it in half to get it out. Sometimes you have to do that. It's quite often actually because it's so scarred up. That is a piece of herniation that is so scarred that it won't even absorb the dye. It doesn't turn blue. It just has a faint blue color from the dye, but it's about 90% scar tissue now, and you cannot get these things out. You can't get them out with drills. You can't get it out with, what do you call it? This guy that does these ultrasonic procedures. He'll be the first person to tell you that ultrasonic machine does not remove soft tissues. All right? And these herniations are soft tissues. So people ask me about that ultrasonic device down South Florida that one of the surgeons does. It's, in my opinion, it's just a joke. I wouldn't even do it. You don't need an ultrasonic machine. All an ultrasonic machine does is remove bone. The only bone that he's removing is your lamina, and that creates a foraminotomy. So he's not even addressing the actual source of the pain, which is the disc herniation, which is soft tissue. It's not a bone. Okay? So, and he knows it. I'm not going to mention any names. A lot of scam artists out there. But that's why we broadcast our surgeries. You can see what's really happening. And we have our testimonials with live patients who've had the surgery. So you can see the truth. Not some fabricated reality. All right, any questions? Just about done here at C6-7. So what's in the foramen over here is the left C7 nerve root, and this is more central. And I'm just looking at this stuff to make sure I'm not leaving anything behind I shouldn't be. This is mostly anterior longitudinal ligament that's very scarred up. We've gotten rid of a lot of bone spurs, and I've gotten the foramen decompressed. I don't see any more herniation there, but I am going to keep looking for another minute just to make sure I'm not leaving anything behind. Again, this is scar tissue and a little bit of herniation here. I gotten rid of the bone spurs that were needed to get rid of. There may be a piece of herniation right there. That's foraminal ligament I'm working on right now. There may be a piece of herniation right there. It looks like a piece of herniation to me. I'm going to have to open this a little more. You can see how horribly scarred this is. This is a degenerated part of the disc. So people ask me, Dr. Duke, can the laser be used to treat degenerative disc disease? The answer is yes, it can. All right, that's the nerve root right there. You guys see it, that blue thing? Not this, that's scar tissue above it. But just below it is the nerve root, the C7 nerve root. Pretty damn cool. You can see all the herniation has been removed. Maybe a little bit right here. Still left laterally. This is the left side at 6-7. Left neuroforamen. Any questions?
No current questions, so we do have a comment from Jonah on YouTube once more, who said, yes, from the whale. Good notice.
Ah, nice. I love stories. And the story of Jonah and the whale is one of the best. And I'm sure your parents obviously appreciated it, like I did. And it's a great story. Great story. All right, we're just about done here. I've gotten rid of as much of this herniation as I can. I've debrided. This is, by the way, the foraminoplasty part of the Duke laser disc repair. It's basically opening up the foramen to get the pressure off the nerve root. And once again, you can see the nerve root right there. I was touching it right here, okay? And the spinal cord would be over here. And I've cleaned everything out. Let's go back and look at the other side. We're fixing 2 damaged discs in this particular patient. We have a busy day today. I think we have 4 surgeries. 2 of them are cervical. 2 of them are lumbar. One of them is a thoracic Duke plasma rhizotomy. That patient came to us from Texas. No. Was it Texas? Arkansas. Yeah, so he's from Arkansas. We're going to get to him later today. And I know we have another cervical coming up. This patient we already said was from Washington State. And she's here with her son who's from California. And like I said, she didn't want a fusion. She didn't want metal in her neck. Nobody should have that done, in my opinion. All right, we're done. Scope off.
Please, scope off. Thank you.
You can see I decompressed the spinal cord and nerve roots. A little bit of antiseptic going in. This is betadine. And betadine is developed by NASA. It's the world's best antiseptic. And it's iodine based. You know I'm going to be putting that down, right? Yeah. So you got to be anticipating that. Huh? All right. Anyway, we're ready to come out. Now this is a technique that was developed by myself at Duke Spine. And I'm going to tell you, the surgeons that do anterior cervical transdiscal surgery, like Dr. Sebastian Reuten in Germany, and Dr. Sang-Ho Lee and Dr. Gun Choi, who taught me in Korea, okay, they only do one disc at a time. And that's because nobody's figured out how to move from one disc to the next disc or a third disc until I developed that technique here at Duke Spine 16 years ago. And basically, I'm about to show you how we do it. It requires us removing the tube and leaving the dilator in the disc, okay? And then once I've done that, you guys can see the tube and the dilator, right? Show them the tip of the dilator. You guys see the tip of the dilator just peeking out like a little turtle's head, and then you got the tube, right? So I'm going to remove the tube first. I keep the fluid adapter on, shot. You're going to see the tube coming out. Show us the tube. There it is, okay? Tube's out. And I'm leaving the dilator in. Show us. Shot. Just take a shot. Yep. There's your dilator. There's my fingers. Show my fingers so everybody knows what that is. Those are my fingers covered with an X-ray reducing glove. So, you know, the surgeon's hands get radiated, and that's not good. It's not healthy for me. But it's a sacrifice I make for my patients. I take that radiation. That's part of the job, you know. 2, 3, 4, 5, 6, 7. So we're going to move up to 5, 6 because we're fixing 5, 6, and 6, 7. So I'm going to bring the dilator out, step 2. You have to do this under lateral fluoroscopy. I can feel when I come out of the disc. I'm almost there. I use the X-ray to guide. Remember, when I come out, I'm going to go north. Shot, there it is. So I've already started going north. North is towards the head, towards the 5, 6 disc. I want to check to make sure that I'm in the middle of the spine. So I'm going to get an AP shot. That's step 3. Again, this technique was developed at Duke Spine by myself to be able to treat multiple disc herniations in one surgery. But it was never done in Korea or Germany. We pioneered it here at Duke Spine. All right, so lateral view, I'm in the middle. You can see the spinous processes. I'm going to keep going north. And to be able to do this, the patient has to be chemically paralyzed. We use
C6-C7 or Nimbex?
Nimbex?
Yep.
How do you spell that? Shot?
N-I-M-B-E-X.
N-I-M-B-E-X. Shot? It's a type of atracurium. Shot?
Yeah,
It's a
son or cousin of Nitrogen.
shot. All right, so now I'm on top of the next disc, 5, 6. Okay, I need an AP to make sure I'm in the middle. But you can see on the lateral view, I'm right over the 5, 6 disc. Quickly. Yep, a little bit off to her left. Shot. Is that it? Shot, shot. So a little bit off to the left. I need to come back a little bit to her right. Shot. That's it. Perfect. So I'm right in the middle. Lateral view. So you go between the AP and lateral views to move the dilator. I'm holding it down on the disc. Now I'm in perfect position. Don't move anybody. I'm going to tap it through the anterior fibers of the annulus. Shot. I could feel it going. I'm going to verify my position before I go too far. I want to check to make sure I'm in the midline. Once again, you count and make sure. 2, 3, 4, 5, 6. All right, we're in the midline. Show us the midline. Show us the endotracheal tube now. Yep. And show us the esophageal temperature probe. See how they're deflected off to the side? Somebody was asking earlier. Okay, I did that originally by putting my hand down on the spine. You know, neurosurgeons don't know how to do this surgery. Orthopedic surgeons don't know how to do the surgery. There's only a few of us in the world, like literally a handful of 5 people that know how to do this. Anterior cervical transdiscal endoscopic. And this is the future of all spine surgery. So you got to ask yourself, why are there so few surgeons in the world that know how to do this? And the answer has everything to do with money. Because these surgeries don't pay very well, and the fusions pay very well. Artificial discs are highly promoted and paid. Yeah, we got to do a discogram. You're right. And so a lot of surgeons do this and they don't get paid for their surgery. I didn't get paid for years and years doing it. Shot? Shot? And the truth is that most surgeons are not willing to make that sacrifice. So you're not going to see this technology very often until reimbursements change. All right, you're doing a discogram. Shot. There it is. You can see the dye just came out. It's leaking out through the back of the disc through a tear. Thank you. I need inline traction. This disc is pretty darn collapsed. 2, 3, 4, 5, 6. A lot of bone spurs back here. Not going to be fun. Inline, shoulder. Yeah. Well, I would like to be a little further back. But I am running into some resistance. This is a pretty collapsed space. Let's see what we can do here. Going to bring the tube. So for those of you watching, the whole surgery is done through a small tube. It's stainless steel, surgical steel. All of this is FDA approved, 100%. People ask me, Shot, is this surgery FDA approved? Yes, it is. All right, let's get a little inline and a little shoulder and shot. All right, you can see the tube advancing through the disc space. And because we're using a dilation process with a dilator and a tube sliding down like a sleeve, we are not causing damage to the disc itself. We're actually just spreading it. Kind of like you'd spread your fingers apart. You don't hurt your fingers when you spread them apart. You hurt them when you cut them off. Other surgeries are like cutting your fingers off. This surgery is just spreading. It's like spreading your fingers. Any questions?
No current questions.
All right. Well, we're getting ready to start our second disc. Yeah, give me some in line. Go ahead. Yep, we got it. That inline traction makes a difference. Yeah, with tight spaces especially. All right, we got this disc to do and then we're done. And we'll move on to our second surgery for the day. Any questions from our audience, Henry?
No current questions.
Wonderful.
Lights on, please. Let's go on, please. Thank you.
All right.
Thank you.
Here we are at the bottom. You can see a little piece of herniation right there already. I'm going to go in and grab that out with my grabber because it looks loose. The problem is if you just use a grabber, which is what the Koreans do and Reuten does in Germany, you're not going to get 90% of the herniation out. Oh, this IV pole is right in my face. Okay, there it is. Can you guys see this? Yeah, thank you.
Yes, we do.
All right, we're at the back of the disc at C5-6, and there's the laser going into action. See how it cleans things out so quickly? And that's because the laser does two things. A lot of people don't understand the second function. Heck, a lot of people don't understand the first function. The laser fiber delivers energy, laser energy. It's what we call electromagnetic radiation, okay? Very powerful, high frequency, short wavelength radiation. It's laser energy, okay? Other types of electromagnetic radiation include radio waves, microwaves, infrared, visible light. Those are all forms of electromagnetic radiation. Again, they all have one thing in common. They all are forms of light energy, what we know as light energy, but it's really called electromagnetic energy. And it has two properties. It has frequency and wavelength. And so all these different forms of electromagnetic radiation are really different in their frequency and wavelength. Amplitude. And the amount of area under the curve tells you how much energy is delivered. Under the waveform, I should say. So the laser happens to be a tool that, you know, Duke Spine Institute, we're not the ones who discovered using it in the spine. It was used in the spine before us. But it was used for a discectomy procedure where they were taking out parts of the disc, and it was done through a needle, just a needle. So it's called percutaneous. Well, that's not what we're doing. We do, obviously, endoscopic surgery. It's very different than just sticking a needle in and using a laser fiber. Oh, Henry, remember we shot that last time? Sticking the needle in?
I believe so, yes.
Where we were going to film it and you were going to give me that excerpt. Can you still do that at some point?
Yes, yes.
Oh, look at that piece of herniation that just came out. Yeah, because I need to show that to somebody, the difference between what we do versus what is a percutaneous laser procedure. All right. So far, so good. We've got 10 minutes left, Doctor.
We have a question.
Sure.
This comes from Jonah once more on YouTube.
Absolutely. Happy to take Jonah's question.
They asked, how can you trust a doctor when they might be incentivized by a private equity firm? I mean, how can I know that a doctor recommendation is really towards my health? Jonah,
Great question. You hit the nail on the head, Jonah. You hit the nail on the head. It's incredible that you said what you said, because that's been what I've been concerned about lately, is all the private equity firms buying into these pain management clinics and forcing the doctors basically to do more procedures that pay better rather than procedures that work for the patient. And that's something Duke Spine doesn't do. We're not sponsored by private equity. We don't get any money from anyone. We do what's best for the patient every time. And that's why we do what we do. We do the Duke laser disc repair. There's no implants. There's no big company making money off of our surgeries because we're putting metal in people or plastic or biologics. The way these companies make money is by putting devices in people, okay? That's where the money comes from, devices. And there are no devices that we put into people with this procedure. This is all natural. This is the very best in the world for patients. But because there's no devices being put in, there's no big companies making money. And because they're not making money off us or our patients or the insurance, they're they don't want this surgery known about. It's basically what do you call it? I don't know, blacklisted by these private equity companies.
Private equity companies are usually found in larger pain management groups, anesthesia groups,
Yeah.
and surgical groups. The larger groups, they
Yeah.
involve.
The way you avoid a conflict of interest with your surgeon or doctor is by going to the Duke Spine Institute. That's really, I hate to say it, but that's how you're going to find the best care for the patient. Not the best care for the surgeon, not the best care for the hospital, not the best care for the insurance company, not the best care for the implant companies. There's a lot of stakeholders in spine, more than any other industry, in my opinion, more than any other field of medicine. Spine has so many hands in the pockets of healthcare, and it's mostly companies that make billions of dollars a year selling implants that go into your body, and all of them are completely unnecessary now, except for rarely needing a spinal cord stimulator, rarely needing metal implants for really bad deformity cases or tumor cases or infection cases where there's instability of the spine. But those are extremely rare. The vast majority of spine care is related to what are called degenerative conditions of the spine. And degenerative conditions really don't need implants. So I don't know what to tell you, Jonah, but your concern is my concern. It's what I talk about all the time. Just watch my videos on YouTube. I'm always talking about the corruption in healthcare, and especially in spine care, and how these companies are basically using patients to sell their products to get them implanted into your backs and necks. I used to do a lot of implants years ago, and that's all I did because that was the best we had as a people. That was the best we had as a spine surgeon. That was the best treatment available. Then I learned about endoscopic, and I started to play with it, and I learned that we could actually fix all the problems that fusions fix, artificial discs fix, the spinal cord stimulators, the interspinous devices, all those things that are implanted. They don't do anything to address the actual source of pain, which is the tear in the back of the disc, which is why people get those procedures done and they're still in pain, because they never address the source. That's a big herniation. Just came out of the left foramen at 5-6. See that thing? Like a golf ball. Now, despite the fact that it looked big, it was really only about 2 millimeters. Remember, the inside of this tube is 2.8 millimeters. So no matter how big the herniations look, there's a lot of them, but they're still small. They're still, around 3 millimeters, 4 millimeters, maybe a big one is 5 millimeters. But because of where they're strategically positioned in the spine, that's why they cause pain, and they cause nerve root irritation or compression. So I have to cut them into little pieces to get rid of them and float them out through the tube. This tube functions as a conduit for the laser and the fibers and everything, and the light and the camera and the fibers that we use to see things, but it also seconds as a garbage chute. So all the garbage just floats right down the chute and out. See that? See how I have to suck it out, basically? I use the irrigation to push it. I use the laser to cut them in pieces, and then we use the tube to float them out. That's really what's happening. No magic, just good medicine, good surgery. Questions?
Yes, we have a question from Explore Majestic on YouTube.
Explore.
Yeah.
Nice.
And they asked, "Great work, Doc. I've been following your channel on YouTube. What of the people outside the U.S. and need to come over to Florida for this surgery?"
I couldn't really hear the question at the end there,
Yeah.
but I heard good job, but I didn't hear the actual question.
The question was, what of people outside the United States and need to come over to
Yeah.
Florida for this surgery?
Yes, yes, we accept people from outside the United States, of course. We want the whole world to come and get this surgery because this is what's best for the patients, safest and most effective. But you have to come to Florida. You know, people come to Florida from all over the world because we have Disney World. I go to Disney World all the time with my wife. We go there to just kind of get some exercise, walk around. And when I'm there, I see people from every country in the world, from Dubai, from Israel, from Mexico, Canada. They're literally from all over the world. They come to Disney World, and we're literally 1 hour from Disney World. So if you can make it to Disney World, you can make it to Duke Spine. After all, the spine is very important, right? You don't want somebody messing up your spine and hurting you, which is what a lot of spine surgeons do. So it's worth the trip. If you've ever traveled to go to a city to visit it for whatever reason, you've had a reason for visiting that city. It has something that no other city has, right? For example, Israel has Jerusalem. If you want to go to the Holy Land and you want to go to Jerusalem, you have to go to Israel. Am I right there, Henry?
Yes, yes.
My geography right? So if you want to go to see the Eiffel Tower, you have to go to Paris. If you want the best spine surgery in the world, you have to go to Florida to Duke Spine Institute. It's not available anywhere else. 5 minutes, yeah. I'm taking some bone spurs off right now. You guys see the laser taking off these bone spurs here?
Yes, we do.
Yeah, that's what bone spurs look like. Yeah.
We have another question.
Sure.
This comes from Explore Majestic once more on YouTube. And they said, that's great. How much will the surgery cost?
Yeah, great question. How much will the surgery cost? So the same thing is, how much will your trip to Paris cost, right? And you don't know until you know what you're going to do, right? I mean, it could cost $1,000 or it could cost $100,000. It depends on what you do in Paris or what you do in Israel or what you do wherever you go. So it depends on what surgeries we're doing. Everybody's surgery is a little different, but the way we figure out the cost is we offer a free MRI review, and you submit your MRI images, your report, and you fill out a questionnaire. Then I look at the report, I look at the MRI, and then we do a Zoom call, you and I, the patient and I, and we talk about what's wrong, where's your pain, and I look at the MRI and figure out, okay, so if the patient's having pain in this area, what's going on in the MRI in that area? And once I see what's happening in the MRI that lines up and matches where their symptoms come from, then I know what surgery you need. Once I know the surgery you need, we know the price, right? So it's kind of like planning a trip anywhere. You want to know what activities you're going to be doing. The activities you do determine the cost of your trip. Great questions. Almost done. This is all just scar tissue. Still a little bit of some bone spur. But we're just about done. Yeah, I'd say 5 minutes now. It's been a bit more difficult than I expected it to be. And that's because the disc is so collapsed. But I feel like we've gotten a lot done that we needed to get done. I just want to go off to this left side. There's still some herniation here that I need to get, and then we'll be done. Any more questions, Henry?
Not at this time, sir.
Henry, any questions?
There are no more questions, Doctor.
I don't hear you, Henry. I don't know if you're talking or not. Wow. This is an old injury. Yeah, we don't hear you talking. I don't know if you're talking or not.
There were no more questions at this
Huh?
time, Doctor. There are no more questions at this
Okay,
doctor.
thank you, Jose. Good to hear your voice, Jose. Oh, I see. Yeah. Just about done. Just want to get this last bit right here. Look at the size of these bone spurs. This is honestly the most bone spurs I've ever removed in any surgery ever. This takes the cake. I mean, not with fusions, obviously. It's actually easier to remove bone spurs with open ACDF surgery using a microscope for me. If that's your goal, is to remove bone spurs. But like I said, most patients don't need a lot of bone spur removal done. This patient is an exception. She has the most bone spurs I've ever taken out endoscopically with a laser. But you see, I couldn't get all this herniation right here without taking the bone spurs out. If you go back and rewind, you'll see it's impossible to get all this stuff out without first removing the bone spurs. So I needed to remove the bone spurs to get access to remove the herniation. All right. 1 minute, unless I find something unusual. That is the foramen right there, the left 5-6 foramen. So you can see there's no more herniation in it, it's gone. I've gotten rid of a lot of the bone spur. This still a little bit more. This is hypertrophied and scarred foraminal ligament. The nerve root's just underneath that. And, oh, there looks like there's a piece of herniation there. Let's turn this. Look at that, hiding. That's why you gotta double check, triple check. Whoever does this surgery, you have to check 5, 6, 7 times, you know, just to make sure, because you don't want to miss it. One minute now, I think, unless, and that is pretty good size there. Hey, is Henry still here or is he gone?
He's here.
Henry? If Henry's still here,
Yes, I'm still here.
tell him I want to save this one as a special video of bone spur removal, cervical bone spur removal. If you could title it that, because this is the most bone spurs I've ever removed in the cervical spine.
You got it. Copy that.
Thank you, Henry.
No worries.
All right, just we're almost done. I'm just trying to wrap this up. You can see all the little pieces of herniation jumping around like little pieces of popcorn in a popcorn machine. Trying to float them out. I got to just take a look at that last thing. Yeah. That's fine. I'm just not getting a good float here. Why? How's my irrigation pressure? So when you can't get a good float out of the fragments, you just got to keep breaking them up into smaller and smaller pieces until they float out. The other thing I can do is blast them out with the what's it called? Betadine. That's what I'm going to do. All right, we're done. I'm going to blast them out with betadine.
Lights on, please. Thank you. We're done here.
All right, great. Surgery went very well for her. We're going to turn off the scope. We're going to basically inject betadine and see how it pushes everything out. So we're going to use irrigation, external irrigation, to get everything out. All right, we're done with 2 discs. I want to show you the incision, folks. This is really incredible. This is why the recovery is just an hour, and these patients go home. Nobody goes to the hospital. There is no hospital. And you don't want hospital when you're doing spine surgery, because hospital is where you get infections, okay? And we don't want infections. We don't want complications. Hospitals are where you get infections and complications. All right, so I'm going to put a little bit of pressure in case there's any venous bleeding, which there rarely is. And my anesthesiologist told me that she's doing very well, that she's going to be waking up in just a few minutes. There's the incision. You guys see that?
Yes, we do.
Where's the measuring thing? Okay, I'm going to bring a ruler. You guys can see how small this is. It's quite literally 4 millimeters. There it is, 4 millimeters. Okay? So it's not bleeding, but we'll put pressure for a minute. And where do you want this? Okay. Any questions from the audience?
Yes, we have a question from Philip Johnson on YouTube. And their question is the airway not moved in this procedure as it would be in a conventional surgery?
Is the airway not moved?
Yeah, is the airway not moved in this procedure?
Yes.
As it would be in a
that's
conventional?
correct. Yeah, I got the question. So in a ACDF or artificial disc surgery, the 2 most common surgeries done worldwide for these disc problems, the fusion, ACDF fusion, and the artificial disc, you would make a big cut and you would have to put pressure on the airway with retractors, metal retractor blades. But we don't do that for the surgery. You're correct. That's one of the reasons why we have no swallowing problems. We have no voice box, hoarseness problems. These patients have none of those complications. The complications are 0 for the surgery in 16 years and over 600 being done. All right, I'll take any other questions when I get there. Henry, if you want to run a testimonial from one of our patients, that would be fantastic. It is February 23rd, 2022. And I'm here with one of my patients who's traveled from Kansas. Is that correct?
That's correct, Wichita, Kansas.
Wichita, Kansas, and clearly you've had surgery. We just did it less than 24 hours ago. You've got your incision there on your neck. How are you feeling today?
Much better. Much, much better. 26 years ago, I had a fusion of C6 and 7. They told me in Wichita that I would need to have fusions of C4 and 5 and C5 and 6. They set up the surgery for the 23rd March, and I'm going, I can't wait that long. This thing hurts, it's killing me, I cannot sleep, and so on. My husband Dale did a whole batch of research online, and he says, I want you to be able to move your neck after surgery.
Yes.
And
I did
he did a
Googling.
lot of research, and we found Dr. Duke to be a man of integrity. He films all of his surgeries. He puts many of them online, and you can see for yourself all the good work that he's doing, and that he really, really likes to help people. What he does is generally not covered by Medicare and not covered by some other insurances, but it very well should be, because it really helps people.
So what was life like for you before surgery?
My pain was mostly in the neck and shooting down my shoulder, and especially in my shoulder.
And you had really bad weakness with your arm. You couldn't even lift your arm, right?
That's
Before
correct.
surgery?
That's correct.
Show us what you can do now.
Before surgery, I could lift it to about here, and now I can lift it.
All the way
Yeah,
up.
just the next day,
You
right
couldn't
after.
do that before.
Yeah, that's because she had a herniated disc, two of them, C4-5, C5-6, and the herniations were literally sitting on the nerve. And we got in there, and if you watch this video segment right here, you can actually see there's the laser, and as we're removing the herniation, it literally pops right out of the frame and where it was sitting on top of the nerve, crushing the nerve. So, and the surgery was a success. We lost almost no blood at all, and you can see your incision is tiny. And here you are one day after surgery. It was outpatient, and you're ready to go home, right? You guys flying
Going
back
home tomorrow.
tomorrow? Okay, very good.
Try and enjoy a little bit of Florida today before we go back to the snow.
Okay, it is snowing there, huh, in Kansas?
Probably.
Okay.
If not today, then tomorrow.
Well, stay another week.
And yesterday it was 70
I
degrees
wish.
there.
70 degrees where, in Kansas?
Or maybe that was the day before it was 70 degrees, and
nice.
then they woke up to about 11 degrees.
Ah, so the cold front came in. We get those from time to time, and it gets cold around 60 degrees. Well, most of the time it's very pretty here in Florida. Well, we're glad you're here. Is there anything else you want to say to the world about herniated discs in the neck and surgery?
Dr. Duke will give you a free look-see on the MRI. It's well worth your time. And he will do a Zoom call with you and tell you what he can do for you. So go for it.
I said that it was so important that I said I'd pay for it. You know, because you know, we got a little bit of a nest egg, and sure it's going to cost a little bit, but it was worth it because we got results. I mean, that's amazing.
Your health is the most important thing in the world, people's health. So
You can't take it with you when you
yeah.
pass away.
All right, folks, we'll have a safe travels back.
Thank
Great
you.
to see you. Glad we can help you out. That's a nice.
Thank you.
That's a nice shake. Good morning. I'm Dr. R. Duke Majan, CEO and founder of the Duke Spine Institute, here with one of my patients who traveled from Mississippi.
Yes, sir. Oxford, Mississippi.
Oxford, Mississippi, which I've never been to Oxford, Mississippi, but I'm sure it's a lovely place.
Very nice.
And why did you come to Duke Spine Institute here in Florida?
I'm having issues with my lower back, shooting a pain all the way down towards my elbow, as well as having a little bit of stumbling while I'm walking within my left leg. And went to other physicians to look at my spine, whatever, and they wanted to do fusion and all kinds of other nonsense that I thought maybe there might be a simpler way, a process of doing things. Did a lot of research and found Dr. Duke here.
And what do we do for you?
You guys did a C3, I think 3, 4, 4, 5, 5, 6 at the Duke laser disc repair surgery.
And before surgery, you had neck pain?
Correct.
For how long?
It's been ongoing probably for about 5 years.
And then pain going from your neck into your right shoulder, down your right arm?
Correct, just getting progressively worse. And that's kind of what made me finally to say I got to definitely do something about it.
Here we are less than 24 hours after your surgery, the Duke laser disc repair. You can see the incision right here, it's 4 millimeters. And do you still have that neck pain and pain in your arm?
No, sir. Zero pain.
Gone.
Gone. Completely gone.
Cured.
In shock. Results better than I actually anticipated, which is a good thing, right? That's what I'm here for.
Well, I'm not shocked. I'm actually, it's what we expect to see typically, which is good. The procedure works, and that's why we do it. It works better than anything else. Were you offered any other treatments?
Yeah, they wanted me to go look at a, what do they call a spinal deformity doctor.
Uh-huh.
And they possibly looked at like doing rods and pins and,
Yep.
and all that kind of good, the fusion and everything. So it just kind of,
Why didn't you want to do the fusion option?
long time recovery time and just more of a difficult surgery.
Yeah.
Much more difficult surgery. And me working at a house, I still want to have good quality of life in the future.
Yeah. Well, fusions have complications, a lot of complications. Scar tissue, bleeding, and pain. Are you having any pain right now from the surgery?
No, not at all. Just a little stiffness when I turn left to right, but that's par for the course.
Yeah, the stiffness is going to take some time to work out.
Sure.
You've had bad arthritis in your neck. Your discs were degenerated. You had degenerative disc disease and herniations and bone spur at C3-4, C4-5, C5-6. We went in and fixed all three. You will need therapy to increase the range of motion. It'll take time and you'll get better. Are you happy with your decision to come to Duke Spine Institute?
Very happy. I flew all the way down here from Oxford.
Yeah, very good.
So absolutely made the long trip. I fly back Saturday, and I feel much better flying on the plane than I did earlier. Just thinking, you know, I'm not on any kind of pain medication, none of the muscle relaxant. There's zero pain, so I feel more comfortable hopping on that plane.
And we did it all through a 4mm incision. You could actually see the incision with the little tube going in to your discs. I moved the tube from one disc to the next, and we went back to the back of the disc where the tear was, and I cleaned the tears up with the laser. So that usually does the trick of getting rid of the neck pain when it comes from a herniated disc. And of course, we unpinched the nerve roots that were going down your arm. So that's why your arm is feeling better as well. I don't expect any of that to come back. You should be pain-free the rest of your life. Just don't re-injure the discs.
Absolutely. I'm definitely glad to get my quality of life back. That's the number one thing.
Anything you want to tell your audience?
Anybody that's dealing with the same issues I have, I definitely recommend to come to Duke Institute of, you know, laser surgery. It's a wonderful thing.
All right. Well, congratulations.
Thank you
Safe
so much. I
travels
appreciate it.
to
Thank
you
you
and
so
Dad.
much.
And if
We
you-
will.
Yeah.
Well, my dad lives in Tampa, so my wife's up there in Oxford taking care of her stuff up there. So
Okay.
worked out good to have my dad here to pick me up and drop me off at the airport tomorrow.
All right. Sounds good. Well, safe travels for you then. Good morning. I'm Dr. Ara Duke-Majan, CEO and founder of the Duke. And I'm Dr. Duke-Majan. I just completed the surgery you were watching here on a lady who came to us from out of state with basically neck pain she's had for over 6 years. Tried all kinds of conservative treatment, didn't work. And of course she had the symptoms that were going down into her left arm, weakness and numbness and tingling, which are pretty common. When you have a herniated disc in the neck, what happens is the nerves that leave your neck and go into your arm, they come out of these little holes right here called the neuroforamen. And the neuroforamen, if you look carefully there, they literally are right behind the disc. So when you have a herniated disc that goes backwards, it hits the nerve by pushing backwards, okay? And that's important because a lot of people are confused about this. You could see right here, for example, this is the lumbar spine, not the cervical, but you can see how the nerves exit the neuroforamen or holes right behind the disc. So when you have a herniated disc sticking backwards, which is the problem, it hits the nerves. Foraminotomy is when you come in through the back, you remove the muscles, ligaments, you drill away the bone here, and then you're still not removing the herniated disc, you're just taking the roof of the house off when the problem is with the foundation. It's kind of a stupid way to fix the problem, but a lot of surgeons do it because that's all they know how to do. What we do is we come through your disc through the front, we get to the back where the herniation is, and I use the laser to remove the herniation and repair the tear. Now once the tear is in the back of the disc is lasered and cleaned and debrided, it will heal itself and you won't have any problems with the disc ever again. It's the only surgery in the world that actually debrides the tear so the tear will heal itself. All of the surgeries that are done do not allow the disc to heal naturally, heal itself. They're all fusing or putting metal, in which case the tear will never heal, the disc will never heal because you've gotten rid of the disc now. You've basically replaced it with a piece of metal. So I don't recommend fusions anymore. I don't recommend artificial discs anymore. I certainly don't recommend going through the back of the neck when the problem is in the front of the neck. The laser surgery we just saw is the most advanced state-of-the-art surgery in the world for herniated disc, bulging disc, ruptured disc, protruded disc, extruded disc, degenerated disc, spondylitic disc, slip disc. I mean, pick your terminology. It's like saying I'm going to have a glass of wine, and then whatever kind of wine you have, it's all different kind of names, but it's all wine. Okay, so all these different names you hear about on MRI reports, on the internet, they all mean the same thing. It's a tear with a herniation of the jelly through the tear. Over time it gets scarred, you get some bone spurs. The laser is able to take care of scar tissue and bone spurs, as well as the herniation. All right, do we have any questions?
No current questions.
Wow,
Yeah.
the audience knows everything. I love that kind of audience. I hope you enjoyed the surgery, and we'll be back again for another patient. This next patient travels to us from England, from London, and she is having a C5-C6, C6-C7 herniation removed as well. Except this time we're going to be approaching it from the left side. This surgery you just watched now was approached from the right side, and she was from Washington State, came to Florida for her laser surgery. The next patient is coming from England across the Atlantic, and she's having the surgery done on her left side at C5-C6, C6-C7. So same two discs, but a different approach. So hopefully you'll join us for the next surgery. Have a great day.